solution. That's the thing with tinnitus and hyperacusis. It's not like 1 + 1 = 2. It's, you actually have to go through many things to see what works with the patient and what doesn't, because some people can really get results in few months, and other needs few years. So it really depends on the approach that we're taking and how much effort and how much patience does the patient have. Dr. Sinno, I'm not sure which idea is it. Is it the CBT one that I just said? Okay, good. Also, regarding the medical problems, actually over 80% of the patients with tinnitus and hyperacusis do not need a medical or surgical treatment. I've seen some patients who have told me that they went into surgery from many doctors because they tried to fix their tinnitus and hyperacusis, and this actually just resulted in detrimental effects in their hyperacusis and tinnitus. It did not help them. It actually put them in worse conditions. So over 80% of these patients just require our help, and they need to know what's their role in this treatment that we're giving them. Now, for the audiologist, there are many audiological tests that we have to go through. First, and I really have to shed the light on that, case history. It's really important to know what triggered the tinnitus or hyperacusis and what other causes are associated with it. We have to really listen to the patient and take all the information that we need. And then questionnaires. Now, the reason why questionnaires are important is that you start the questionnaires at an earlier time, and then you continue, and then at every session you make the patient take the questionnaires again and see how is it evolving, and is it getting better, is it getting worse. So that's how it, and there are many questionnaires that are there. I can definitely, maybe off the course, suggest some of these questionnaires for both tinnitus and hyperacusis. They're all really good. There are some that are used really in the research section, but I can definitely give you a list. And also there's otoscopy and tympanometry, which is really important. However, the acoustic reflexes can be done with tinnitus patients, but do not do them with hyperacusis patients. This information is not really important for the hyperacusis side, so let's just remove it. Specific questionnaires for pediatric patients. I haven't been working lately with any pediatrics who have hyperacusis. I have seen some. I know there's one questionnaire that is really for the pediatric population, but it's mainly how the parents see it, and how that's why some questionnaires are actually filled by the parents when you're working with a child, and others you just kind of work with the pediatric population, with the child itself. I can definitely try to recommend some of these questionnaires, but as for the pediatric psychoacoustic evaluations. Okay, so these psychoacoustic evaluation, yeah, actually I have them in the next slide. I'm going to talk about residual inhibition. The incidence of tinnitus in the pediatric population, that's a really important question because actually if you think about the pediatrics population, well, adults can tell you that can tell you about the description of the tinnitus. Hold on, I'm sorry. The adults can tell you about their description of the tinnitus, what they're feeling, and their description of it. But with the pediatric population, it gets really hard. It's not easy for a child to really describe what they're feeling. It's really different between adults and the pediatrics. So any statistics that is there for the pediatric population, it might be skeptic. So they might tell you that it's only in 10% of the population, but is it really? Like, do all children know that tinnitus is something wrong? Is it something that they should report to their parents? That's why the incidence of tinnitus in the pediatrics population is not really out there. It's really the psychological side of it is really important. If If it can fade psychologically without any help, that's great, because that's really all our goal. Someone asked me to explain more about LDLs. Now, just for the sake of time, I will go over the slides and finish them, and then I will explain more about LDLs and answer the rest of the questions, if that's okay. Okay, now clinically, for the tinnitus, some audiologists have been doing the pitch matching, and that is used really for masking and residual inhibition. The pitch matching, is when you tell the patient that, okay, I'm going to present multiple frequencies, and I want you to tell me what is the frequency that you think is closest to your tinnitus. And then you can provide a masker, which is really a sound generator at this frequency. Residual inhibition is a concept which is the suppression of tinnitus following a period of masking, which means that you can provide masking for this patient for a period of time, and there have been many research about what is the best period of time, and we still do not have like the best answer for that. But however, when this patient hears a masking for this period of time, he actually can report either a suppression of the tinnitus, and some others have reported really just the disappearance of the tinnitus, because it's just that some people said that it's like my ear received a shock, and this shock has decreased the tinnitus completely. Okay, I will unmute you, Dr. Smith. There you go. Okay. Now, the tinnitus retraining therapy is really the most important part of all our discussion, because TRT also falls under hyperacusis. Also with hyperacusis, it's really important to follow up with what we call contour tests of loudness. These tests have not been in the past. They're actually kind of new. It's where you give a list to the patient and you tell them, okay, can you please tell me the loudness of the sound? And you present at a really low level, and then you gradually go up in the volume. And then you test what is very soft and what is uncomfortably loud for them. And then with the sessions, session 1, session 2, up until the last session, you still do this loudness perception, and you see how is it. Is there a shift in the most uncomfortable level that they have, or is it still the same? So that's how you actually can see if there's any improvement with them. Now, what is TRT? TRT is actually divided into two components. One is the hearing device part, and the second is the counseling, which is the really the most important part of it. For the hearing device, this hearing device may include a sound generator. Now, as you may read in the articles, they refer to noise generator, but whenever I'm working with a patient, I make sure not to mention the word noise, especially if I'm working with a hyperacusis patient. With tinnitus, it might be less severe with them, but I just refer to it as sound generator. And this sound generator can be, for example, like a seashell sound. The seashell sound can go over and over in the hearing device. Now, you may say that this might be annoying, but it really isn't, because you really put it at a comfortable level, and this comfortable level is not set by you, it's actually set by the patient. And this, why is it important? Because hearing the sound over and over again really comes into play with the neuroplasticity. Neuroplasticity, I'm just going to kind of give an introduction for some people who don't know. Neuroplasticity is the ability of our central nervous system to adapt to changes in the environment. So when our brain is constantly hearing this sound over and over again, you're kind of making it adapt to sounds or in the environment. And for tinnitus, you actually make it pay attention to it and not pay attention to the tinnitus. For hyperacusis, your brain will think that this ongoing sound is really normal, so it starts kind of stabilizing the importance of sounds in your environment. This hearing device, in progress with research, now research is going into what we call loudness suppression. And this is mainly for hyperacusis, because it's where hyperacusis patients tell you, no, there is no way for me to stop wearing earplugs. Like it's kind of a comfort zone for me. It's what protects me. So, okay, you tell them, you will not wear earplugs, but I will give you a substitute. And you put what we call loudness suppression, which means you set a limit in the hearing device, and you tell the device above that limit, don't let any sound come in. And this limit is also set by the patient. So you're kind of giving control to the patient more than the audiologists have control. And now the counseling part, which is really important, because in the counseling you kind of tell the patient, look, this is what's happening in your system. This is how treatment might help you. And what is your role in doing that? Why can this work? And really, by counseling, research has proven that it can be really, really important, because some controlled trials have tested the sound generators without counseling, and they did it together and saw the effects. And really, it has proven that the addition of counseling in the treatment is really important. So why does TRT work? First, for tinnitus, it provides masking. As I said, it normalizes the gain in your system. I'm sorry, we are going a little bit over time, but just to answer the questions. So it normalizes the gain in your brain. It kind of tells your brain that, okay, let's give importance to something else. Let's pay less attention to the tinnitus or to this sound that I'm hearing in the ear. Of course, counseling, where you give the patient a sense of control. When the patient knows what is happening in his or her system, and they know what's their role in this treatment, it actually gets the patient into faster results and long-term results as well. For hyperacusis, it also normalizes the gain in our brain. As I said, the loudness suppression can be protection. And the counseling, also the same thing for tinnitus, and why is it really important? I have this graph on the right side. It just really illustrates how when our system, usually everything that you're seeing in the green is something that's really normal. And we know that the limbic system, which is important for our emotions, and the autonomic nervous system, which is responsible for our physiological responses like fear, anxiety, or feeling under attack, are really associated. There are connections between those two systems with our auditory cortex. So when there's any problem or any increase in the gain in our auditory system, these systems are also associated. So these systems also play an important role. If they are like not working correctly, this might create a vicious loop from these systems to our auditory cortex. As we are more uncomfortable with the sounds, as we are more fearful, our emotions become stronger and stronger. As our emotions become stronger, we also have more negative associations in our auditory cortex. So that's why the importance of having a psychologist, we always talk about it, because everything is connected. Our auditory system is not separate than our other systems. That's just a clinical case that it's actually not for me. It's actually taken from one of the doctors I've worked with. His name is Dr. Craig Formby, and he actually put this in his article. As I mentioned, he put separate groups. Okay, separate groups. Some groups had noise generator without counseling. Others had placebo noise generators. Others had noise generator with counseling and without counseling, sorry. And now he saw that the biggest shift in the uncomfortable loud level was really when you combined the noise generator and the counseling. So he saw a positive shift in these categories, and of course the biggest effect. Now, as for conclusions, I want to just reiterate that there's effective evidence-based non-medical techniques to treat both tinnitus and hyperacusis. We should give more time for both of these populations, because really usually if we are working with a patient that only needs hearing aids, it's really like we want to run from one appointment to the other. But this population really needs our attention and really needs our time, because every patient is different than the other in all forms. Sound enrichment, which is introducing environmental sounds to our brain, it helps our brain know what is normal and abnormal. And then it's really important to follow up with these patients using questionnaires, using like different sessions, and even phone calls sometimes are important, especially now we're all stuck with at home or just quarantined. We don't just stop seeing these patients. Sometimes emails or even phone calls are really important, and it makes the patient feel comfortable and that he's being followed up. And there are so many resources for reading that you can give for the patient too when he leaves your clinic or whatever you're seeing him online, like from ASHA, from American Academy of Audiology. There are many resources that you can give for the patient to give him a sense of control. And that's the end. Thank you so much. I will take questions if we have time. I know we have 8 minutes. Okay. Okay, Dr. Suno, I just unmuted you.
Perfect. There is one person who asked about pediatric tinnitus. I would say out of personal experience, I've seen children outgrow tinnitus. We have seen personally, I have seen tinnitus related to a concussion. I have seen tinnitus that is related to braces, imagine it, dental work leading to tinnitus, but these both are reversible. The things that I saw that were not reversible in children are post-chemotherapy. These are the cases of tinnitus or acoustic, or if we have tumors and auditory or vestibular or even facial nerve. These are the kids where you know that definitely you need to put more effort. The children, in my opinion, that would require the most of your time would be the juvenile Meniere, where the tinnitus there is very annoying to the child. I think we have a few questions.
Yes, I'm currently reading the questions. I have a question. Do plasticity works even in so-called associative areas, not properly just in acoustic areas? Has anyone ever used transmagnetical stimulation, transcranial magnetic stimulation? So there have been a lot of research, especially with animals, actually, that have used these techniques because it's really hard to use them with humans. But the plasticity actually does not work only with the limbic system and the autonomic